Charcot-Marie-Tooth Disease. Charcot-Marie-Tooth Disease is the most common hereditary neurological condition. The disease is a polyneuropathy which causes degeneration of the peripheral nerves. There are two types of the disease, Charcot-Marie-Tooth Disease Type 1 and Charcot-Marie-Tooth Disease Type 2. The difference between the two neurological conditions is that Type 1 presents with demyelination of the thicker, myelinated, fast-conducting axons, for example, the alpha motor neurons, and Type 2 presents with degeneration of the nerve axon. Genetic makeup is the biggest contributor to Charcot-Marie-Tooth disease. The most common phenotype can be caused by up to 100 gene mutations. Most genes causing Charcot-Marie-Tooth disease have dominant inheritance, meaning that the disease will be passed on to the next generation. However, there are also recessive genes present in the rarer cases. This means that the disease may or may not be passed on. There are various ways to diagnose Charcot-Marie-Tooth, including a blood test to identify genetic issues, nerve conduction studies to measure strength and speed of electrical signals, EMG to measure nerve communication with muscles, and a nerve biopsy. Charcot-Marie-Tooth disease, being a polyneuropathy, presents axonal loss with prolonged myelination. This in turn causes a slow decline in distal muscle strength and sensation, which primarily affects the longer peripheral nerves. Charcot-Marie-Tooth disease affects approximately 36 in 100,000 people. As previously mentioned, there are two types of the disease. A systematic review conducted in 2016 revealed that the frequency of the two types varied from 37.6% to 84% for CMT1 and 12% to 35.9% for CMT2, thereby indicating that type 1 is more common than type 2. The prevalence of the disease is shown to be most common in Iceland and least common in Norway for CMT1, whereas CMT2 is at its largest in Norway and its lowest in the United Kingdom. In regards to gender differences, males are shown to have a higher prevalence of CMT, 16.6 per 100,000 people, when compared with females, 14.6 per 100,000. It is also noted that the highest prevalence of the neurological condition is at its highest in individuals aged 50 to 64 years, 25.2 per 100,000 people. Some common comorbidities of CMT include obesity, depression, anxiety, and osteoarthritis.
Charcot-Marie-Tooth syndrome is a degenerative disorder that affects the distal segments of the body before progressing to cognitive dysfunction down the track. Some common signs and symptoms in the upper limb include weak fingers, poor fine motor skills, weak grip, and contractures. In the arm, we can see atrophy and weakness of the muscles, which can result in poor wrist extension and flexion. In the lower limb, it also consists of muscle weakness and atrophy due to reduced neural stimulation, balance and stumbling gait, pain when walking, and in the toes, it can cause hammertoes, contractures, and high arches due to weak peroneal and tight tibialis anteriors. There are also slight differences between the two types, as is all relative to the gene that is affected. Depending on which type you have, it can affect when developed disease, which part of the periphery is mainly affected, and how severe the disease can be.
When comparing the ICF framework to Charcot-Marie-Tooth disease, body functions and structures are affected due to bone and muscle deformities that can affect things such as range of motion, muscle force, and gait. Activities are also affected, as people with Charcot-Marie-Tooth disease are most likely not to be able to perform certain activities due to their decreased capacity level. Participation is also another issue, as people with Charcot-Marie-Tooth may miss out on certain sports due to their decreased capacity to other people. Environmental issues further exist, such as public transports, climbing stairs, and even just walking outside can be an exhausting task. Personal factors such as age and gender may also affect a person with CMT, as bullying may occur. Overall, all these factors can influence the mental state of a person with Charcot-Marie-Tooth disease, and it is therefore important to modify when available to reduce comorbidities such as depression and anxiety.
The benefits of exercise for a person with Charcot-Marie-Tooth disease is highly advantageous in terms of symptom reduction and especially the slowdown of peripheral denervation. Although modification need to be administered, a person with Charcot-Marie-Tooth are likely to have decreased capacity in most aspects of physical fitness. In the current evidence, there is positive results regarding improvements in cardiovascular fitness, resistance to exercise, and flexibility/balance training. Evidence surrounding cardiovascular exercise in a study by Mori et al. In 2020 recently found that after 3 months and 6 months of treadmill training, they can improve performance in the 6-minute walk test, which can correlate to improvements in their VO2 max. Similarly, articles by Wallace et al. And Durstein et al. Have found cardiovascular exercise to increase functional capacity, social interactions, and pulmonary functions, leading to better breathing patterns. On the other hand, resistance training has also been seen to be beneficial in these patients. Byrne et al. In 2017 found progressive resistance training maintained dorsiflexion strength 24 months after starting the intervention in children aged 6 to 17, preventing atrophy and denervation. Furthermore, exercise training and testing which utilizes assessments such as the timed up and go, handheld dynamometer, and movements such as the sit to stand is an effective assessor of lower body functional strength in patients with Charcot-Marie-Tooth. Lastly, the benefits of exercise regarding flexibility and balance is extremely significant for patients with Charcot-Marie-Tooth. As over time they develop contractures and stiff muscles, their range of motion decreases along with their balance. It is also seen that patients with CMT have reduced sensation and may not even know they're performing movements or even have abnormal gait that could be potentially harming them. Numerous studies have applied stretching and proprioception training and found improvements in measures such as the Berg Balance Scale, 10-meter walk test, improved lower limb range of motion, single leg balance, and heel to toe stretching. Therefore, the benefits of exercise for patients with CMT appear to positively influence their quality of life and can reduce some of the issues previously addressed on the ICF framework.
When we look at the issues regarding neuroplasticity in Charcot-Marie-Tooth patients, we see denervation at the neuromuscular junction, motor axonal sprouting, and demyelination of the nerves. Physical activity can play a crucial role in reversing this through the mechanism of use it or lose it, especially when we are talking about neurological disorders. Several studies have assessed physical activity and the physiological adaptations that can occur. In a systematic review by Sman et al., they found that participants who engaged in any form of physical activity had improvements in strength, functional performance, and neurological adaptations. More specifically, it was shown in Valdez's study that exercise and calorie restriction resulted in neuromuscular junction sparing in the tibialis anterior and gastric, along with postsynaptic denervation spared and improvements in demyelination. Overall, seeing preserving results for Charcot-Marie-Tooth patients. In the treatment process of Charcot-Marie-Tooth disease, exercise professionals involved include a physician, orthopedic surgeon, podiatrist, exercise physiologist, psychologist, speech therapist, physiotherapist, and occupational therapists.
The bottom line for treatment options and medication for people with Charcot-Marie-Tooth is there is no cure, and it is all about managing the symptoms as best as you can. Braces like shown in the picture, orthopedic devices, and shoe insoles have been developed over the years to provide customization to everyone for comfort and pain relief. Pain relief is one of the most significant treatment options there is, such as non-steroid anti-inflammatory drugs are typically common for muscle injuries, and certain anti-epileptic drugs can also treat the neuronal pain. With the emerging body of research, potential future treatments are still in the works but are showing hope for a cure in the future. With the limited information available, evidence around improving the myelination of the Schwann cell and keeping the axon alive is the most researched option. Evidence by Young et al. And Sahank et al. Dived into neurotrophin-3 as a potential candidate for artificial neurotrophic factors to replicate hormones such as brain-derived neurotrophic factor and nerve growth factor. Likewise, evidence by Kagaeva et al. And Ozes et al. Specifically looked at the Schwann cell therapy and targeting the AAV9 gene to also help produce these neurotrophic factors. All 4 of these studies showed significant improvements in reinnervation of the nerve. However, in these studies, the effects only last approximately 1.5 minutes. Not only this, there is currently minimal evidence produced in humans, and it is an invasive strategy and could lead to negative effects if gone wrong. Lastly, in the last 2 months, there has been new insight on new potential treatments known as apigallocatechin 3 gallate. This was a case study, however, and it looked at the differences between a guy and a girl who were brother and sister. One of them had Charcot-Marie-Tooth disease type 2 and the other was normal. They used this treatment as like a form of T over 6 months to see how differences can change. They found that there was an improved 2-minute walk test, 10-meter walk test, 9-hole peg test, and hand grip strength. So that is definitely another potential option to look forward to in the future.
Overall, there is no treatment for Charcot-Marie-Tooth disease. However, exercise is very effective in alleviating the symptoms associated with it.